So a brief introduction about Anne. Anne Carroll is a registered nurse with a certified neonatal nurse practitioner, and she's worked for many years, 40 years, 30
Yeah.
years.
Well, 40, yeah,
40 years at Maine Medical Center in the NICU. And so she is quite a specialist in her field. And she and I have been traveling the world for a while, going to different places. And we partnered up with going to Uganda several years ago and she works a lot with Malago Hospital, which is a 1,500 bed facility in Kampala. And they have a big NICU over there. And she will share with you some of her stories and her experiences being a medical mission nurse in a NICU in a developing country. And so we want to welcome Anne and want to welcome all of you and thank you for joining us. Anne.
Hi, everyone. I'm so glad you could join us tonight for this talk on Uganda. So when I was thinking about what to do, I was realizing that it's nearly 20 years since I have gone to Uganda. So we're going to kind of look at what's happened over the past 19 years and the people, the different hospitals, and the different programs that I've been involved in, as well as some of the volunteers. So we're going to get started. And Kayla, what do I need to hit the
share screen? Green button on the bottom.
There's no green button. Oh, there it is.
Okay. Share your screen. Oh. No.
Can you help her? And then just hit the center button in the right corner. This one right here.
Oh, way over here.
Here we go.
Okay.
It's not up there.
It's not sharing. Sorry, guys. Technical
Technical.
difficulties. We're getting there.
Because I had hit. Yeah.
You just have to click that one. Here we go. There we
Okay.
go.
Okay, here we go.
All right. Finally, we're ready. Okay, so I entitled this, as I said, Neonatal Nursing in Uganda. My first trip was in 2001, and most recently I was there in 2020 and had hoped to be there in 2021, but it looks like we may not get there for another year or so. So if you're not aware of Uganda it's on the east of Africa, and it's surrounded by Sudan, Ethiopia, Kenya, Tanzania, Rwanda, and the Democratic Republic of the Congo. That lake you see there is Lake Victoria. So a little bit about the demographics. The population of Uganda is 45 million, and the capital is Kampala. The major language is English, as it was a former British colony, gaining independence from England. They also speak Luganda, which is a local dialect, and then there are many tribal languages spoken throughout the country. 85% of Ugandans are Christians and 11% are Muslim. Agriculture accounts for 60% of the economic growth, with major exports being coffee, tea, and tobacco. Recently, in the past 20 years, we have seen a great growth in tourism in Uganda. And unfortunately, due to the COVID travel restrictions, tourism has completely closed off. So there are a lot of people in Uganda without now any source of income because so much of it was based on tourism. It's a state, it's about the size of our state of Oregon. There are 48 different ethnic groups. The largest is the Baganda, which is 17%. And because they border so many different countries, there are refugees who come from the Sudan, the Democratic Republic of the Congo, and Rwanda. The equator passes right through Uganda, and it's also the source of the Nile. So when we traveled there, we were able to step on the equator and have our feet in the northern and southern hemispheres. This is a group of nurses and respiratory therapists who traveled with me to Uganda in 2015. So just a brief history that it gained independence from Great Britain in 1962. And most people are familiar with Idi Amin, and you may have seen the movie The Last King of Scotland. If you have seen that movie, the hospital that they show there is actually Mulago Hospital. He fled there in 1979. So when I first went there, people kept asking me, oh, isn't that where Idi Amin was? And I said, he has not been there since 1979. And he died in exile in 2003. So it was very hard hit by the HIV epidemic in the 80s. And many people had traced the source of some of the infections to Uganda. It peaked in the early 90s, but Uganda was one of the first countries to really promote safe sex, use of condoms, and they were actually able to decrease their incidence of HIV. There was an Ebola outbreak in 2012. And when we went in 2015, we had Ebola, if you'll remember, here in the United States. So we actually had to be screened going into Uganda because they were afraid that we might be bringing Ebola into their country. The life expectancy of men is 52 years and women 54 years. And I just put comparable statistics in the US where men is 76 years and female is 81 years. So there's still a lot to be done healthcare wise. The fertility rate, the average woman has 4.9 children compared to 1.8 in the United States. And if you look at the maternal mortality, it remains really high, 430 per 100,000 live births. In the US, it's 24. So this picture is pretty dramatic. And these were twin babies. And most mothers feed their babies by pumping fresh breast milk. So mothers are responsible for coming in every 2 hours to feed their children. So if nobody comes in or nobody is aware, then those babies may not get fed. So this is just a reminder to staff that these babies need to be taken care of. Neonatal mortality remains high, and that 20 per 1,000 live births, and in the US is 4. So neonatal mortality is death during the first 28 days of life. And these are just, we'll go into a little more depth about the different hospitals. These are pictures on the bottom taken in the NICU at the old Mulago Hospital. Maternal death, intrapartum death, and premature births, 28%. Babies die of sepsis, pneumonia, congenital anomalies. Yeah, those conjoined twins are actually now 19 years old, living happily in the US after being adopted by Dr. Cindy Howard. So this looks like a really dramatic, scary picture, but we like to show it just because on my very first trip to Uganda, Ellen Milan and I were working in the nursery on our very last day, and these babies arrived 10 days, and I believe they came from Gulu, Elizabeth. Wow. And we said, what are we gonna do? Oh my goodness. Fortunately, there was a pediatrician, Cindy Howard, who was working with us. We told her, she arranged for them to be taken to Maryland where they had surgery. One of them also had a heart condition, and she ended up adopting them. And now they are happy, well-adjusted 19-year-olds. Yeah.
Get a picture of them now.
I do have one, but I couldn't find it. But yeah, they're amazing. They're beautiful, and it was a real success story. So infant mortality is death during the first year of life. So in Uganda, it's 33, and in the US, it's 6. So they're pretty dramatic statistics. And again, childhood mortality is deaths before the age of 5. And in the US, we have 6.6, and they have 46. More males than females die. So what happens when you go for the first time in 2001 to a NICU? That you have no idea what, there had been no nurses in this unit, and Ellen and I arrived with a a mannequin to teach some neonatal resuscitation. We thought that might be a good idea. But we looked at what are the other challenges facing the nursing and medical staff there. And first and foremost was keeping babies warm, which we take as just a given in our NICUs. Every baby has their own incubator. Not so, as you'll see as we go on. Supporting babies with breathing problems. They had oxygen there, but they have to share it. Adequate fluids and nutrition. Again, they didn't have IV pumps to give IV fluids. They're starting to get some now. So nurses literally had to stop every 2 hours and push IV fluids by hand. And this was under grossly inadequate staffing, which I will show you a little bit about later. Again, no drugs, no supplies, no equipment, like basic antibiotics, things we go to our cupboards for or our drawers at work, getting out syringes, IV catheters, feeding tubes. Feeding tubes, sometimes there are no supplies in the hospital. The mothers have to be given a prescription to go out to a local pharmacy to literally buy a feeding tube to feed their premature baby. And then they have to wait for the staff to have the time to be able to put that feeding tube in. So it's a huge challenge just to be able to feed these babies. There are very few heart rate monitors, especially when we first went there. And again, all the supplies that we bring are used again. They're cleaned almost to the point of being destroyed, but they refuse to throw anything away. So all the equipment gets used and reused and cleaned. And most of that equipment is brought by volunteers. So this was the first hospital we worked in where you saw some of those previous pictures, and that is Mulago Hospital. It was actually opened in 1960 by Princess Margaret of the UK. And at the time, as it was associated with Macquarie University, which had a medical school and still does, also has a bachelor's nursing program and a master's nursing program, was considered really one of the state-of-the-art hospitals in Africa at that time. It was 1,500 beds, and it was the largest hospital in Uganda. Unfortunately, when Idi Amin came to power, the whole medical system crumbled and is still in recovery from that time. So they really weren't able to progress through the 70s and 80s, even though they had a great start and were doing really well. This is the original special care nursery where we work. So they get over 3,000 admissions per year. I remember one day when we were there over the new year, they had 99 admissions in 24 hours. They had done 60 cesarean sections, and at that time, most of them were done under general anesthesia. So it's incredibly busy. The average census it can be 50 to 100 babies, and the mortality rate in that nursery is 60%. So because it's such a crowded place, and because Uganda is really dusty, they make everyone change their shoes going into the nursery. So those are the shoes that belong to the parents or people coming in and out. So you always have to remember, and that's what we tell everyone who's coming to volunteer in the nursery, make sure you bring your extra pair of shoes because you need to change it. And you don't want to be going around barefoot, although a lot of the mothers, they don't have extra shoes. So parents and mothers are all walking around barefoot, and you got to watch out for needles and things on the floor. So what is the nurse? And they also have midwives there who, they are trained midwives, so they do deliver babies, but they also work in the NICU taking care of babies. So this is our patient ratio in Old Mulago Hospital there, 18 nurses. Now that's their total staff, and that's to cover 24/7. So they have 3 to 5 nurses on a shift. So in our NICU at Main Med, we have 30 intensive care beds, 31, and 20 step down beds. So we would have, maybe 17 or 18 nurses a shift, plus 2 respiratory therapists, a neonatologist, 4 nurse practitioners, a pediatric resident, as well as all the support services like occupational therapy, physical therapy, pediatric pharmacy, nutrition, speech. So there are really no support services over there. The nurses pretty much do everything. The physicians are not necessarily there 24 hours. And when we first went over there, they were definitely not there 24 hours. So there may be one, maybe 3 nurses on at night who would admit the babies, start their IVs, put them on oxygen, give them their initial doses of antibiotics. So the nurses have an incredible amount of responsibility. That's why the mothers and fathers now are required to come in and feed their babies every 2 hours. The nurses just barely have time to get in the medications and the IV fluids. So feeding is always done by the family. So you can find babies everywhere in Old Mulago Hospital. In the NICU at Main Med, each baby in our 50 rooms has their own room, their own incubator, their own linen, their own cart of supplies, and their online chart. These babies, these are plastic chairs that you might sit outside in your yard in. So in the morning when you would come, you just kind of look around for babies, and, you know, they may be warm. They may have blankets. Now these ones look pretty good because you can see they do have hats on. They are wrapped up, and that piece of paper on top of the baby is their medical record. The babies don't get lost. I really was surprised to find that when you asked a nurse about a certain baby, even though they got moved around a lot, they could identify that baby. They knew where it was, and they knew who the mother was that baby belonged to. They do tape identification on their arms after they're born as well. So it's amazing how they keep track of those babies, but I assure you, they know where they are. These are where you find the babies in the morning. That's kind of like an exam stretcher. So we would kind of arrive in the morning, and these were where the newest patients were placed until they could find a bed for them. And these were the full-term babies. So you can see that some of them have oxygen, some of them where you see that tape wrapped around their arms, that's where they have an IV fluid. So they're not attached to IV pumps because there aren't any. So when they get fluids or antibiotics or any other kinds of medications, they're given through their peripheral IVs. And the nurses are the best I've ever seen at starting IVs. They are really expert. And I know sometimes when I've tried, I couldn't get an IV in, but they can always get an IV in. They are very skilled in that. So babies are everywhere. Again, these are just metal trays. That first baby up in the corner who's kind of looking out under all the tubing, I think that I had gone to a C-section delivery and kind of resuscitated that baby, but I put that baby there because I really didn't have time to take the baby out to the mother or to the nursery because I was going to receive another baby on the top level there. So that one just had to, yeah, that one just had to wait and was doing fine, was wrapped up, was warm and safe. I could keep an eye on him. This other little one on the bottom, I think is afraid he might fall out of bed, but I never saw babies fall out of chairs or off benches. They stay safe somehow. They're smart. Again, you can see that's one bassinet on the right there, and that has, I think, 5 babies in it. These are not babies who are related to each other. So these are just spaces for babies to be put in. So they just go wherever they can find a space. And this was initially the old Mulago Hospital. And you will see as we go along, there have been improvements. This nursery no longer exists. This part of the hospital was taken down, and it was very old. And this is how they share their oxygen. So you had only a couple of flow meters attached to the walls. And so in order to get a nasal cannula or CPAP, which is continuous positive airway, which is a little higher level of respiratory support, to a baby, you had to snake all these tubes together. And you can see why I'm so crazy about those Y connectors when I find them over here at Partners for World Health, because they're like gold, attaching all these oxygen tubings together. And one of the first things you want to do when you walk into that nursery is make sure everybody's connected up. And believe me, I've tripped over that tubing a lot. And you can see it goes from that one flow meter that's up on the wall down to all that tubing, and then snakes out to all the babies. The picture with all the syringes is how the nurses give the fluids. So they don't just hang an IV at the beginning of their shift. They have to literally sit and draw up each syringe individually. And it's they get dextrose. They may get some normal saline mixed with it. In another bin are the meds. And then they go to each baby and they give by hand those IV fluids and medications. And unfortunately, if the IV is infiltrated, they have to stop, start an IV, and keep going. So, and remember, this is for all of those babies, maybe only 3 to 5 nurses. If you're lucky, there may be some students who are helping. And then after the baby's discharged, the tubing is all thrown in a sink and then it gets washed. And it's usually with some kind of solution, that strong cleaning solution or bleach. And then it's hung out over the window there to drip dry to be used again. And God forbid you throw something away with them seeing it. So I learned to sneak away things that I didn't think were good enough to be used on a patient, because they would just continue to use them.
Like we have to do with Elizabeth.
Yeah, that's why she does well in Africa.
So you
No
got your phone.
waste. And this is their medical records system. So I don't know how you find a particular patient's chart, but that's where they were. Not quite like our electronic medical record. Even our paper charts weren't quite that bad. So this again was in 2015 when a team came from Maine Medical, and we were joined by Ellen Milan from Partners for World Health and Health Volunteers Overseas. And Faith Henry, who's a respiratory therapist in the NICU at Maine Medical, we started an educational program to show them how to use some of the equipment we brought, because part of our goal is not only to bring supplies, but to provide the education to use those supplies correctly. So this is the continuous positive airway education, actually given by a respiratory therapist for the first time. So Faith was the first respiratory therapist, I think maybe in all of Uganda, at least for sure, whoever came to that neonatal unit. So she was really helping them learn. So we conducted a lot of education, and we started doing it with mannequins so that people could try out the equipment using the mannequins and picking the proper size for each baby. Then it was followed by an educational program. We left them with slides with a poster and some resources. So we don't want to just bring medical equipment over there and just expect that they know how to use it properly. So we always want to provide education. So again, this is what it looks like to begin to pack for a trip. All of the supplies that we bring are hand carried in bags. So this was the trip in 2015. So a lot of these supplies were donated by Maine Medical Center, some blankets and clothing by family and friends, some other things we got from Partners for World Health. So there were 4 of us traveling at this time. We each had a personal bag. So we had 15 bags of supplies to bring with us for the unit. And this is what it looks like when you arrive. And then you have to bring all those bags and sort them out and find what you're looking for. Hopefully we keep a packing list inside each bag, and then we try to distribute the supplies and put them away and then provide the education. So as Mulago Hospital closed and that NICU was torn down, the NICU was moved to Kawempe National, now a referral hospital. This hospital was built in 2017 as a maternal child hospital. It, however, was not equipped to handle the NICU that ended up over there. So they did not have enough incubators, enough oxygen. They literally started out with oxygen tanks without wall oxygen, and the tanks would tip over or they get disconnected. It was very unsafe. Finally got some wall oxygen, but the population of babies just kept increasing. So I think they would have as much as maybe 120 babies at a time. These are adult patient care beds, and this is the term infants. Some of them with a blue tubing are on continuous positive airway pressure. Some are on oxygen. Some have feeding tubes. So there's no incubators for these term babies, and they can stay warm better than the prematures. So the incubators and the warmers are relegated to the smallest babies to try to help keep them warm. So on the side, you can see these are the where the kind of overhead warmers are. Those are the small babies. And again, one baby is not for one incubator or for one warmer. As you can see, there are 3 in a warmer, and they're all sharing oxygen as well. So again, the average daily census could be up over 100 babies. So what happens when you bring people to this NICU? Well, first we try to prepare them for what they might see. And we have volunteers, new grad nurses, and we even have volunteers coming into our nursery. This was the Partners for World Health trip in, I think it was 2017 or 2018, where students they can help out. They can make sure the oxygen is connected. They can take temperatures. They can just even say a kind word to the mothers and the families who don't get a lot of attention and support. So if you're hesitant about coming on a medical mission, we can find something for you to do. There's plenty to do. And I think some of the people who have been in the nursery found that out. There's a lot to do, and you don't have to be a trained professional. Just making sure the oxygen tubing is hooked up is a full-time job. So some more new graduate nurses. Again, they're just assessing the babies, and then I'm always there with them. So if they think this baby doesn't look well or there's something wrong, then go and get a nurse, a doctor, or me, or somebody who can take care of the baby. And we also have abandoned babies. So sometimes mothers leave the hospitals without their baby. So the baby is essentially adopted by the staff of the nursery until it can be taken to either adopted or to an orphanage. So they don't have bottles with nipples because they're really hard to keep them clean, and they just don't have a supply. They do have syringes. So this is basically a 20 ml syringe, and people will buy formula. The doctors or the nurses will buy formula for the baby, and then the baby will just eat with a syringe. And believe me, they do very well with pacing and time they swallow. I mean, I think they know it's survival for them. And if you just take your time feeding them, then they will do fine until they're removed from the nursery. But people love to feed them, and they buy them clothes and diapers and things like that. So if they are abandoned, they are adopted and taken care of by the staff. But some of the people, volunteers, love to go and feed the babies. So Kawempe now, because of the overcrowding and because Mulago has been closed, they are now opening a new neonatal unit. Now, I haven't seen this unit. It opened in the summer of 2020. And you can see it looks now more like a neonatal unit you might see in the United States or in a developed country. But there still needs to be education, because now they're getting equipment and using medications that they're not used to using. So there's still a lot of room for education, because just because you see the equipment and you see the supplies doesn't mean it's all understood or that it's being used correctly. So that will continue to be part of our mission going to Uganda. So this is just some of the equipment. You can see it looks a lot different from the first hospital we looked at, which was Mulago. Still very busy. So with Partners for World Health, we have traveled to Gulu, which is in the north of Uganda, and it's a referral and teaching hospital, but it's a very small community hospital. It's not huge compared to the NICU that you saw at Kawempe and Mulago. They do have a nice little NICU with a very devoted staff. They have, again, when you see these equipment, these isolettes and everything, it looks great, but be advised that they often don't work. So in fact, when I looked at this room when I was there in 2019, I guess, they couldn't, I said, why aren't these isolettes plugged in? And they said, because we don't have a power strip and there's only one outlet here. I said, okay. And you can see this, the oxygen tank there is, they don't have wall oxygen. So the oxygen is coming off of that big tank. So what could we do? So we could go down to the store and we could buy them a power cord. And they told me that this was in January that they had put in to get a power cord. And this is Dennis, who is an experienced nurse that I had met before. And he said, we put it in November and it was now January. They hadn't received a power cord. He's also holding batteries in his hand because they had no batteries for their pulse oximeters. So we decided we would just take a little trip downtown with our driver, who got us the best deal in the best store. We had to go to several stores before he was comfortable with the price that we were paying, which by our standard wasn't a lot. But anyway, so we brought it back. It seems a simple thing, but to have an isolette and not be able to plug it in means that the babies are going to be cold. And hypothermia is one of the leading causes of death, especially in premature babies. So it doesn't matter how much equipment you have. If you cannot keep the babies warm, they will not survive. Across the street from the old Mulago Hospital is now the Mulago Specialized Women and Neonatal Hospital. So this is got all the equipment, and it's no longer sort of the referral hospital. It's a specialized hospital, and it is more like a private hospital. They charge a fee, so they don't take the multitudes of babies that you saw at the old hospital or at Kawempe. They will take in transfer some of the sickest babies, but it is not being used yet to its full capacity, which is a little disappointing to the nursing staff who work there and to us. So hopefully they will be able to figure out a way to use it to best serve the population that needs it so desperately. So one of the things that we do in Partners for World Health, and one of the best ways to prevent sick babies, is to have a healthy pregnancy. So Partners for World Health has Project 10,000, which we have been doing in Uganda. And this is an educational program for pregnant women. And we teach them about what are the signs and symptoms that something could be going wrong with their pregnancy, what they should look for, how they should eat, just to try to make them healthy. And what you see on the table there, it's called a mama kit. So it has all the items that a mother needs to bring to the hospital. Because when you go to the hospital in Uganda, you are not provided with linens or even sterile gloves for your midwife. So the mothers need to bring in, there's a bulb syringe there, there is sterile gloves, there's blankets, there's all the things that, there's a drape, there are things that they need to have for their birth. So this is a very wanted thing because they'd have to pay for it if we didn't provide it. So, and along with the educational program, when they finish, they get this birthing kit that they take to the hospital when they have their baby. And we have found a lot of complications of pregnancy when we begin the teaching program, because we kind of just look at people, their vital signs are taken, their blood pressure is taken, and we ask them how they're feeling. Several times we have found mothers who are hypertensive that we have sent to right to the hospital because their blood pressure was dangerously high. We had a mother last year in the village who had actually a molar pregnancy, which was abnormal development of a placenta and fetal tissue. She was bleeding, and if we had not picked that up in our screening clinic, she would have died. She was taken to the hospital by the Partners for World Health team, admitted, and I think she would have just bled to death and not, if she had not come to our clinic. So this is just an example of how you can make an impact when you go to a developing country. And these classes, this is what you're faced with when you arrive to do a clinic. Word of mouth spreads. People come and they will wait very patiently, and we take them in groups of 10 or so to do the teaching so that we can really, and there are some times when we literally have had to close the gate and we just run out of birthing kits. We run out of time during the day, but when we arrive in the morning, we will see all these people just waiting to come to a clinic. And I think this is a great way to do prenatal teaching. And also one of the safest ways to prevent premature birth is to make sure the mother has a healthy pregnancy. So you can't do this alone when you go to a developing country. You got to have partners. So I have worked with health volunteers overseas. That was the first organization that I went with, and Partners for World Health. Ellen Milan, who is a neonatal nurse, has been going to Uganda since my first trip in 2001. Yvonne Vaucher is the neonatologist from University of California, San Diego, who convinced us after her first visit to Uganda that neonatal unit needed some nurses. Dr. Margaret Nakakato is a pediatrician who has been very involved in neonatal care. We first met her in 2001, and we're still working with her up in Gulu and at Kawempe Hospital. Damali Mogawera, who you'll see a little bit later. She is a midwife, and she's also a nurse educator. So we first met Damali, Ellen Milan and I, in 2002. She was kind of thrown into the NICU, and she thought she was being punished because she was afraid and because she had had no education in how to take care of a sick baby. So what we did was provide the education, and she grew to love it. She never wants to do anything else. And because of her exposure to health volunteers overseas and Partners for World Health, she's now an educator who travels around the country of Uganda doing educational programs. She was actually asked at one point, before she came to the US, when did you go to the US to get this education? And she said, I didn't. They came to me. So we actually did bring her to Maine Medical Center and to the University of California, San Diego for experience 2 weeks in each of our NICUs. And I'm going to talk a little bit about that, how important it was to bring her here and how much we actually learned from her as well. And I think it was a great experience for the staff in both hospitals. So this is one of our first trips. That's Dr. Vaucher, Dr. Nakakato, and Ellen Milan. And then there's Ellen and I as we continue to go back. Those are our Uganda scrubs. We bought the fabric there and then had them make us scrubs. And this is the Partners for World Health team last January. And this is Damali when she came to visit Partners for World Health. And she actually gave a little talk on what it was like to be a nurse in Uganda. And Dr. Nakakato is still involved. Those are some of the supplies that I brought. We're sorting them out. When I was there in January, she introduced me to an obstetrician who was a pregnant obstetrician who was working for the United Nations. And so she wanted me to talk to her and discuss what was happening in Kawempe Hospital. So this woman said, I'm going to help. And, you know, you hear that a lot and you hope that maybe, but so this other picture of, this was March. This was a supply that came from the United Nations. So she actually followed through, and this truckload of supplies came from the United Nations. So I think actually bringing her, and I don't remember her name, I wish I had taken it down, into the nursery, showing her the babies, showing her what was inadequate. And also at the time, Dr. Nakakato was working on developing the new unit that was going to open later that year. So these supplies were crucial, not only for the patients that were there, but for setting up this whole nursery. So hopefully they will continue to support. So we brought Damali with the help of family, friends, and we thought, well, you can come in April. It'll be nice. I don't know if you all remember April of 2019, but we got snow and she was not prepared for snow. She'd never seen snow. She's had never traveled to the US and never mind to Maine. So with the help of my friends, we got her a down jacket and leggings and boots, and because I walked to work, so she had to walk to work with me in the snow. So she thought Maine was very cold. It was an observational exchange, but she was assigned as part of the team with a nurse. So the nurses signed up to work with her. So you can see that Sandy that day was scheduled to work with Damali. So she followed them for the whole day. She had nothing to do with me. She's seen me work. She's seen me teach. So what was important to her was to interact with the nurses one-to-one on the floor. And she's also, you could find her anywhere learning something. So she was, this is in the blood gas lab in the NICU. She's learning how we do blood gases and having a little class from respiratory therapists who are invaluable in teaching. So she learned, and these are a group of nurses and respiratory therapists that she worked with. And she said one of the best things about working in the hospitals here in the US was the teamwork. It wasn't the equipment that she was excited about. She'd seen equipment, she'd seen NICUs, but what she said was when a baby was really sick and somebody needed help, that all they had to do was call for help or ask for help or ring the buzzer, and a whole team of people would show up and help. So I think what really impressed her was teamwork, working together, and the fact that everybody still cared about the babies, cared about the families, and were really involved. So that's what she said she wanted to take home from this experience. And that kind of wasn't what I really thought. I thought she'd be thinking about, well, I want us to buy this kind of equipment. I want us to have that. And it wasn't. What she said is, I want us to learn to communicate and work better together as a team. So I think that was really important for us to learn that, it's not for us all about the equipment either, that communication and support is really what helps the team work together. And when she left, we do what we always do in the NICU at Maine Med, is have a party and and buy gifts. So she had a great experience, and I know she had a similar experience at the University of California, San Diego NICU. So if you go to Uganda, it's a busy, hectic place, but it's also a really beautiful country. And you can go on safaris, and we still go crazy over the baby animals. So I just had to show you my baby animal pictures.
Look at the little. Wow.
Aren't they cute? Yeah. You can go rafting if you're adventurous on the Nile. And we went gorilla trekking. I've actually been 4 times, and getting to see the silverbacks. And this is a mother holding a baby. You get to spend 1 hour with them after you hike to see them. So, thank you very much. And I guess Webele is thank you in Lugandan.